Welcome back to the deep dive. We've got a serious stack of textbooks on the desk today. Miller's Anesthesia, Morgan and Mikhail, Stolting the ICU book, and we are doing something a little different. We're shifting gears from general interest into full-blown exam mode.
That's right. We're role-playing the high-stakes scenario. Imagine you're a postgraduate student. You're sitting for your MD anesthesiology exams, let's say specifically at Gujarat University, known for being pretty rigorous.
Right.
The coffee's gone cold, the stress is high, and you're staring at a 20-mark long question.
And the topic isn't some obscure syndrome. It is the absolute workhorse of the ICU and, the labor ward.
Magnesium sulfate.
MGSRO.
The physiological calcium blocker.
The jack of all trades. I mean, if you're an anesthetist, this molecule is your best friend and just occasionally your worst enemy.
Okay, so what's the mission today?
Our mission today is to take this massive topic and distill it into a structured, high-yield audio guide. We aren't just chatting. We're literally building the perfect answer for that long theory question and arming you for the viva voce. Because this pops up everywhere, doesn't it? It's not just one little section of the syllabus.
Oh, everywhere. You'll see it as the long question. Describe pharmacology, mechanism, and uses. You'll see it as short notes on, say, M in preeclampsia. Yeah. Or magnesium toxicity.
Right.
And I guarantee if you're in a Viva and you mention muscle relaxants, a sharp examiner is going to pivot to magnesium interaction. If you stumble there, they smell blood.
Okay, let's make sure nobody stumbles. We're going to break this down exactly how a candidate should structure their answer paper. We have 15 distinct sections to cover to ensure you get full marks. So let's start with section 1, introduction. How do we frame this immediately to grab those marks?
You have to start with its identity. Don't just say it's a drug. Magnesium is the second most prevalent intracellular cation, right behind potassium.
Ah, okay.
And overall, it's the fourth most common cation in the whole body. You establish immediately that this is an essential electrolyte, not just a pharmaceutical you pull off the shelf.
It's biological machinery.
Exactly. It's a cofactor for over 300 enzyme systems. And we aren't just talking about, digestion. We're talking about the heavy lifting of life. Energy metabolism, protein synthesis, nucleic acid stability.
So for the anesthetist, where do you pivot from there?
For the anesthetist, you pivot to its triple threat role.
Which is?
Obstetrics, cardiology, and respiratory. It is the absolute gold standard for eclampsia. It's the go-to for Torsades the point, and it's the savior in acute severe asthma.
So the strategy is establish its physiological dominance first, then move on to the clinical utility.
Precisely. That segues you naturally into section 2. The physiology of magnesium. This is, and I can't stress this enough, very high yield. This is where a lot of candidates lose points because they just skip over the basics. You need to know the rule of location.
The rule of location. You mean where magnesium actually lives in the body?
Yes, and it's a bit of a recluse. About 50 to 60% is locked away in the bone. This is a slow exchange pool. It doesn't just flow into the blood whenever it's needed.
So it's not readily available?
Not at all. Then you've got the intracellular compartment, skeletal muscle, and liver that's holding about, say, 20 to 40%.
And the blood, the serum level that we actually measure in the lab report.
That's the trap, less than 1%. Specifically, the plasma contains only about 0.3% of the total body magnesium.
That's a tiny, tiny fraction. So if I draw blood from a patient and the magnesium level comes back as normal,
it tells you very little about their total body stores. You can have a patient who is intracellularly depleted, essentially running on empty, but homeostatic shifts keep the serum level looking pretty for the lab report.
Ah, so that's a classic Viva question then.
A classic. Why is the serum magnesium normal in a malnourished patient?
Because the blood is the last thing to give it up. The body defends that ECF concentration.
Perfectly put. Now, physiologically, there are two massive concepts you need to mention to show you understand the mechanism. First, ATP. We talk about ATP as the energy currency, right?
Mm-hmm.
But biologically, it exists as a magnesium ATP complex. No magnesium, no ATP function. It's that fundamental.
And the second concept?
A pump agonist role. This is what connects magnesium to potassium. The sodium-potassium ATPase pump, the little engine that keeps our cells polarized.
Essential for life, yeah.
Yes. Well, magnesium is an obligate cofactor for that pump. If you don't have magnesium, the pump fails. This leads to something we call refractory hypokalemia.
Refractory meaning just stubborn.
Exactly. You have a patient with low potassium. You give them potassium IV. It doesn't go up. You give more. It still doesn't go up. Why? Because without magnesium, the cell cannot hold on to the potassium. It just leaks out through renal wasting.
So the big takeaway is If the potassium isn't fixing, you have to check the magnesium.
Always. Every time. And finally, it's a relationship with calcium.
Hmm.
Magnesium is the physiological calcium antagonist. It competes with calcium. Where calcium excites, nerve firing, muscle contraction, magnesium relaxes and stabilizes.
So a deficiency would lead to irritability?
Right. Neural irritability gives you seizures. Cardiac irritability gives you arrhythmias.
That is a perfect bridge to section 3, mechanism of action. If we're writing this in the exam, this is the core pharmacology. How specifically does it antagonize calcium?
You have to get granular here. Don't just say it blocks calcium. You need to say it competitively antagonizes calcium at voltage-gated calcium channels, specifically the L-type channels. It physically sits there and prevents calcium from rushing into the cell.
And this is happening everywhere in the body.
Yes, but the exam money is on the neuromuscular junction, the NMJ. This is what the anesthesia examiner really cares about. It has a dual effect here.
Presynaptic and postsynaptic?
Correct, and the presynaptic effect is the dominant one, the primary one. Normally, an electrical signal hits the nerve terminal, calcium channels open, calcium rushes in, and that influx triggers the release of acetylcholine vesicles.
Right.
Magnesium blocks those calcium channels at the nerve terminal.
So no calcium entry, no vesicle release.
Or at least a dramatically reduced release of acetylcholine. That's the big one. Postsynaptically, it also does a couple of things. It decreases the sensitivity of the motor end plate to whatever acetylcholine does manage to get across, and it decreases the excitability of the muscle membrane itself.
But the main point to remember is the presynaptic blockade.
Visualize that presynaptic blockade. That's the key to understanding why it causes muscle weakness and why it interacts with our drugs.
What about in the brain? We use it for seizure, so it must be doing something in the CNS.
This is the NMDA receptor antagonism, the N-methyl-D aspartate receptor. This is the glutamate receptor, and glutamate is the brain's main excitatory neurotransmitter.
Okay.
Normally, the NMDA channel is plugged by a magnesium ion at resting potential. You can think of it like a bouncer at a club door.
It keeps the channel closed, keeps the riffraff out.
Right. If you're magnesium depleted or there's a massive wave of depolarization, that bouncer leaves, the plug is removed. Calcium floods into the neuron, causing excitotoxicity and eventually seizures.
So by giving MGSO, we're basically putting the bouncer back at the door.
We are restoring that physiological blockade. It is absolutely neuroprotective. And because it also blocks this process of central sensitization in the spinal cord, it has analgesic properties too.
And just briefly on the heart, how does it work there?
It slows the rate of the SA node firing,
Yep.
and it prolongs conduction time through the AV node. It acts very much like a pharmacological calcium channel blocker, think Vervemil or diltiazem, but it's one our body makes itself.
Okay, that makes sense. Moving to section 4, pharmacokinetics. This can be a bit dry, but we need the high-yield bullet points for a short note, or the VIVA.
Absolutely. Bullet point 1, absorption. Oral absorption is terrible, only 30 to 40%, and it's saturable. That's why we never, ever treat acute severe conditions with pills. It has to be IV.
Or IM. I've heard of IM regimens.
You can give it IM, and you should know about that for obstetrics, but it's notoriously painful, and the absorption can be inconsistent. 4B is the standard for modern anesthesia.
Okay. And distribution.
The volume of distribution is similar to the extracellular fluid. Protein binding is about 25 to 30%, mostly to albumin. The active fraction, the part that does all the work, is the ionized part, which is roughly 60 to 70%.
And the really crucial point.
You need to write this in capital letters in your mind. It crosses the placenta.
That's absolutely vital for the obstetric section later.
Yes. The fetus equilibrates with the mother. Whatever the mother's plasma level is, the fetus sees it too.
What about getting into the brain, the blood-brain barrier?
It crosses poorly, actually, which is a bit of a paradox, right? But it's effective enough to stop seizures. The concentration in the CSF doesn't rise as drastically as the plasma, but the anticonvulsant effect is very robust. Now for excretion, this is what I call the renal rule.
Let me guess, it's all kidneys.
Almost entirely. It's freely filtered at the glomerulus. But here's the little physiology nugget that gets you extra points. The major site of reabsorption is the loop of Henle, specifically the thick ascending limb.
Which is different from sodium.
Very different. Sodium is mostly reabsorbed in the proximal tubule.
So why does that specific location matter for the anesthetist in the OR?
It's less about the location and more about the absolute dependency on renal function. The entire safety margin of magnesium is dependent on the GFR. If a patient has renal failure, they cannot excrete the load you give them. If you give a standard loading dose to a patient with anuric renal failure, they can hit toxic levels in minutes.
So renal failure is a massive, massive red flag.
It's a flashing neon sign. You must adjust the dosing.
Okay, let's move to Section 5, pharmacodynamic effects. We know the mechanism, but what does the patient actually look like? What do we see?
Let's climb the systems. CNS, sedation. Now, it's not a general anesthetic. Don't make that mistake in the exam.
Yeah.
But it definitely sedates. It raises the seizure threshold. It also causes cerebral vasodilation, which is key in eclampsia to help relieve that vasospasm.
Neuromuscular.
Weakness, skeletal muscle relaxation, and, as we'll discuss, profound potentiation of non-depolarizing blockers.
Cardiovascular.
Vasodilation. That's a direct action on the arterial or smooth muscle. This is what causes the classic flushing and sensation of heat that patients complain about. Doctor, I feel like I'm burning up. That's the vasodilation. It also, of course, lowers blood pressure.
Is there a sympathetic component to that?
Yes, it is antiadrenergic. It inhibits the release of catecholamines from both the adrenal medulla and the sympathetic nerve terminals. We sometimes call it a chemical sympathectomy.
Which is why it's useful in something like a pheochromocytoma.
Precisely. It dampens that massive adrenaline surge during surgery.
And finally, respiratory.
Bronchodilation. It's the same principle. Smooth muscle relaxation in the airways thanks to calcium antagonism.
Which brings us perfectly to Section 6, clinical uses. This is the real meat of the long answer.
Number 1, undisputed champion. Obstetrics, eclampsia and severe preeclampsia. The Magpie trial, a massive international study, proved once and for all that magnesium sulfate is superior to phenytoin and diazepam for preventing recurrent seizures. It's not even a contest.
It's not just a sedative, it's actually fixing some of the underlying pathophysiology.
Exactly. Number 2, cardiology, Torsades de Pointe. This is a specific type of polymorphic ventricular tachycardia that looks like a twisted ribbon on the ECG. Magnesium is the drug of choice. Even if the patient's serum magnesium level is normal, you give a bolus to stabilize the cardiac membrane.
Okay, number 3.
Acute severe asthma. Here it's an adjunct. You've given the salbutamol, you've given the ipratropium, you've given the steroids, the patient is still tight. You start a magnesium infusion, it relaxes that bronchial smooth muscle via calcium antagonism.
And the others you'd mention in an exam?
Pheochromocytoma for intraoperative stability during tumor handling. Tetanus to control those horrific muscle spasms and autonomic storms. And increasingly as a component of multimodal perioperative analgesia, using it to reduce opioid requirements.
Let's double-click on Section 7, MGS-ORO in obstetric anesthesia. You said this is absolutely essential.
You cannot pass an OB anesthesia station without this. You need to know the regimen concepts.
Yeah.
Historically, there was the Pritchard regimen.
That's the IM one, right?
Yes, deep IM injections in the buttocks. Very painful. High risk of abscess. But you need to know it exists. Modern anesthesia almost exclusively uses the Zuspan regimen, which is an intravenous infusion.
And the concept the examiner wants to hear is?
Loading dose, followed by maintenance dose. You have to give a large bolus up front to rapidly achieve a therapeutic level, then you follow it with a continuous infusion to keep it there.
Because you have to get them into that therapeutic window fast to stop the seizures.
Right. Now imagine that same patient needs an emergency C-section. What are the big implications of the magnesium she's running on for you, the anesthetist?
Well, you just said it relaxes smooth muscle, and the uterus is one giant smooth muscle.
Bingo. Uterine atony. Magnesium is a tocolytic, meaning it relaxes the uterus. After the baby is out, the uterus might not clamp down effectively, leading to a massive postpartum hemorrhage or PPH.
So you need to be ready.
You need to be ready with your oxytocin, your methergin, your carboprost. You need to be one step ahead of the bleeding.
And what about her hemodynamics?
Hypotension. Profound hypotension. These patients are often hypertensive to begin with, so they might be on labetalol or nifedipine. You add magnesium, which is a vasodilator, then you do a spinal anesthetic, which causes a chemical sympathectomy.
So it's a triple hit.
It's a setup for a precipitous drop in blood pressure. You need to be very proactive with your fluids and have your vasopressors, like phenylephrine, drawn up and ready.
And the baby. You mentioned it crosses the placenta.
Yes, the neonate can be born with what we call floppy infant syndrome, hypotonia, poor muscle tone, and respiratory depression. The pediatrician needs to be warned. Mom is on MAG. They might need to support the baby's breathing for a little while until it clears the drug.
Okay, that's crucial. Now, Section 8. The interaction with neuromuscular blockade. This is the Viva trap you mentioned at the start.
This is where they catch people. Magnesium significantly potentiates non-depolarizing muscle relaxants. So your Vicaronium, rocuronium, cisatricurium.
Potentiates meaning it makes them stronger.
Stronger and longer. Much, much longer. Remember the mechanism we talked about. Magnesium reduces acetylcholine release presynaptically, and it reduces sensitivity postsynaptically. The muscle relaxant is also blocking the receptor. It's a double hit on the NMJ.
So if I give a standard intubating dose of rocuronium to a patient on a magnesium infusion.
The intubating dose itself is usually fine for getting the tube in, but the duration of that block will be significantly prolonged. The real danger is the maintenance dose, or the top-up. If you give a standard top-up, that patient might not breathe for 2 hours. You must reduce the dose, sometimes by 25 to 50%.
And what about waking them up at the end? Reversal.
This is very tricky. Neostigmine, our standard reversal agent, works by inhibiting acetylcholinesterase. This increases the amount of acetylcholine in the cleft to compete with the relaxant.
But magnesium is actively stopping acetylcholine from being released in the first place.
So neostigmine is fighting an uphill battle. It's a tug of war. It might not win. The reversal can be incomplete or wear off. You might think they're strong, you extubate them, and they develop respiratory failure in the recovery room.
So what's the solution? How do you manage this safely?
You cannot fly blind. You absolutely must use a peripheral nerve stimulator train for monitoring from start to finish. You need objective, quantitative evidence of recovery before you even think about pulling that tube.
And what about Shicomedics?
If you have it, Shicomedics is the preferred agent for reversing rocuronium or vicaronium in these patients. It works by a completely different mechanism. It encapsulates the drug chemically, so it doesn't rely on that compromised acetylcholine physiology.
Yeah.
It's much more reliable.
Does any of this affect succinylcholine?
Not nearly as much, no. Succinylcholine is metabolized by plasmacholinesterase in the blood. Magnesium might prevent the fasciculations, those muscle twitches you see, but it doesn't dramatically prolong the block like it does with the non-depolarizers. Okay, Section 9. Adverse effects and toxicity. We need to memorize the clinical ladder. This is just pure data you have to have learned for the exam.
Yes. You need to visualize a thermometer. The therapeutic range for eclampsia is roughly 2 to 4 millimole. Or, in the American units you'll see in some books, 4 to 8 millimole.
What's the very first rung on the ladder of toxicity? What do you see first?
Loss of deep tendon reflexes, specifically the patellar or knee reflex. This happens at about 4 to 5 millimolar or around 10 millimicor.
And this is exactly why the nurse is checking the knee jerk every hour on the labor ward.
Exactly. It is the physiological warning shot. It happens before the really dangerous stuff. If the reflexes are gone, you are knocking on the door of serious trouble.
What is the next rung up on that ladder?
Respiratory depression. At around 6 to 7 millimole, or 12 to 15 millimole, the diaphragmatic and intercostal weakness becomes so profound that the patient stops breathing.
And the final terminal event, cardiac conduction defects. You'll see a prolonged PR interval, a wide QRS complex, and that progresses to cardiac arrest or systole. This happens at levels greater than 10 millimoles or above 20 LEQL.
So the sequence to burn into your brain is reflexes go, then breathing goes, then the heart stops.
That is the mantra. Reflexes, respiration, cardiac, in that order.
Which brings us to Section 10, management of toxicity. So you're the senior resident on call. The nurse pages you. The eclamptic patient on magnesium has stopped breathing. Walk us through the algorithm.
Step 1, stop the infusion. First thing, don't think, just stop the source of the problem, turn off the tap.
Step 2.
ABCs, airway and breathing. The patient isn't breathing because of profound muscle weakness. You need to secure the airway, intubate, and ventilate them. This buys you time.
Okay. Step 3, the antidote.
Calcium. You need to flood the system with the physiological competitor, calcium gluconate or calcium chloride. Usually it's 1 gram of calcium gluconate the 4th, and you give it slowly over a few minutes.
Why slowly?
Because a rapid bolus of calcium can cause its own problems, like bradycardia or arrhythmias. But functionally, the calcium goes to the neuromuscular junction and the cardiac cells and outcompetes the magnesium at the channel sites. It restores neuromuscular transmission. It essentially wakes the muscle up.
And after the antidote.
You support the circulation. They'll likely be hypotensive, so fluids and vasopressors. And remember, if the reason they got toxic was because of renal failure, that magnesium isn't leaving the body on its own. They might need diuretics or even urgent dialysis to physically wash it out.
Okay. Section 11, anesthetic and ICU implications. Let's try and synthesize all this for our daily work.
Pre-op. You have to look at your patient. Alcoholics, patients on long-term diuretics, the critically ill, these people are often magnesium depleted even before they see you. Check the electrolytes. And you must check the creatinine.
Because of the renal rule. Always.
Intra-op. Be very careful with your induction agents. Propofol causes hypotension. Magnesium causes hypotension. They synergize. Reduce your muscle relaxant doses and monitor them with a nerve stimulator. And something people forget, monitor temperature.
Temperature? Why temperature?
Yes, that profound vasodilation promotes heat loss. These patients get hypothermic very, very fast. You have to keep them warm with a forced air warmer.
Good point. Okay, section 12, contraindications. When do we just say, no, we can't use this drug?
Well, renal failure is the big precaution, or relative contraindication. But the absolute contraindication you must remember for your exams is myasthenia gravis.
And why is that such an absolute no-go?
Think about the pathology. Myasthenia gravis is an autoimmune disease where the body attacks the postsynaptic acetylcholine receptors. The patient already has fewer functioning receptors.
Right.
If you then give magnesium, you block the presynaptic release of acetylcholine.
So you're attacking the neuromuscular junction from both sides. You're cutting off the supply and blocking what few receptors are left.
Exactly. You can precipitate a full-blown myasthenic crisis and total paralysis. It is incredibly dangerous.
Any cardiac contraindications to be aware of?
Heart block. If a patient already has a slow conduction system like a pre-existing AV block, magnesium will slow it down even further. You can easily turn a partial block into a complete heart block or a systole.
Oh, okay, fantastic. Section 13, the Viva traps. Let's prepare the listener for those cricky curveball questions.
Okay, trap 1. Why do we check the knee jerk? The simple answer is to check for toxicity. The good answer is because the loss of the deep tendon reflex occurs at a lower serum concentration than respiratory depression. It acts as a built-in clinical safety margin.
I see. It's the early warning system. Okay, trap 2.
Can you reverse muscle relaxants in a patient on magnesium? The answer is yes, but with extreme caution, as reversal with neostigmine may be incomplete due to presynaptic inhibition of acetylcholine release. Then you pivot. Therefore, quantitative neuromuscular monitoring is mandatory, and sugammadex is the preferred reversal agent for steroidal relaxants in this population.
Perfect. Trap 3.
I have a patient in the ICU with hypokalemia. I have given them 100 millimoles of potassium, and their level is still 2.8. What is wrong?
You need to check the magnesium level, as hypomagnesemia causes refractory hypokalemia ddue to failure of the neck AT-pace pump.
That's the one. And trap 4, is magnesium an anesthetic? The answer is an emphatic no. It is a sedative, an analgesic adjunct, and a powerful anticonvulsant. But you cannot perform surgery under magnesium alone. Historical attempts to use it as a sole anesthetic agent resulted in toxic, often fatal levels being required. It is an adjunct, not a replacement.
Got it. Section 14, presentation. We're in the theory exam. We have a pen and paper. What should we be drawing?
2 diagrams will get you maximum marks. First, the neuromuscular junction. Draw the nerve terminal. Draw the voltage-gated calcium channel being blocked by a big MD++ co-circle. Then draw the acetylcholine vesicles just sitting there, unable to dock and release. It explains the entire mechanism in 2 seconds.
Simple, effective. And the second diagram.
The toxicity thermometer. Just draw a vertical line. On the left side, put the serum levels in MEQL, 4, 8, 10, 15, 20. On the right side, line up the clinical signs, therapeutic range, loss of DTRs, respiratory depression, cardiac arrest. It organizes your thoughts and shows the examiner you know the numbers cold.
Brilliant. So, to wrap this all up, section 15, the summary and exam conclusion.
Let's boil it down. Magnesium is nature's calcium blocker. It is essential for ATP function and the sodium-potassium pump. It lives mostly in the bone and cells, so serum levels can be misleading. Its pharmacokinetics are entirely defined by renal excretion. That's the renal rule. Its clinical home run is eclampsia. Its major danger is toxicity, especially in renal failure, which progresses predictably from reflex loss to respiratory arrest. The antidote is calcium, and you never ever trust a muscle relaxant dose in a patient on magnesium without a nerve stimulator.
So if you can articulate that structure, identity, physiology, mechanism, clinical uses, and toxicity, you aren't just passing that question.
You are crushing the exam. I mean it. Mastering magnesium is a real badge of honor for a safe and knowledgeable anesthetist.
Visualize that NMJ diagram. Visualize that toxicity ladder. To all the postgrads listening, especially those prepping for the Gujarat University exams, you have got this. Thanks for listening to this deep dive.
Good luck.